Now, I would like to introduce Dr. Helen Burston, the moderator of our next panel, which will discuss incorporating patient-driven value measures into oncology. Dr. Burston is the Chief Scientific Officer of the National Quality Forum, the NQF, a not-for-profit membership organization that works to catalyze healthcare improvement through quality measurement and reporting. She provides strategic guidance to all of the forum's work from the perspective of current and emerging measurement science, while also providing scientific oversight for the evaluation, endorsement, and selection of quality measures and the transition to electronic performance measurement. Before joining NQF in 2007, Dr. Burston was the director of the Center of Primary Care, Prevention, and Clinical Partnerships at the Agency for Healthcare Research and Quality. She's also served as assistant professor at Harvard Medical School and the director of quality measurement at Brigham and Women's Hospital. Please join me in welcoming Dr. Burston and our panelists. Thank you for joining us here.
Thank you all for joining us today. We're really excited to have this panel as our panelists come in here. It's really quite a privilege to follow the patient panel, hearing the perspectives of patients as we begin thinking about how other perspectives come into that value equation. I can't think of a better way to launch into our panel. So before we do that, I'd like to introduce each of our panelists. First to my left is Richard Bankowitz. Richard is the Executive Vice President for Clinical Affairs at AHIP, America's Health Insurance Plans. Has been previously a premier, has spent a lot of time in this space of thinking about how to use data in particular to drive quality and value. Next to Richard is Dr. Maria Kohler, who's the Vice President for Strategy and Innovation and Collaborations at Pfizer Oncology. Next to Maria is Randy Hillard. Oh, nope, sorry, it's not. Randy's one over. Randy is a professor of psychiatry at Michigan State University and perhaps also has this remarkable distinction of also serving today on our panel as also a patient. And he'll share his, I think, somewhat unique perspective, although we heard a little bit of that in the earlier panel as well, of what it's like to be an ultra-informed patient and still trying to get what's needed through the process. And then finally, we have Dr. Schwartzberg, who is the executive director of the West Cancer Center. So as you can see, we've got lots of perspectives here up on the podium in terms of both those who work in the area of plans, direct providers, academia, as well as the patient perspective. So what we're hoping to do here is really take an opportunity to really reflect on some of the prior presentations. And I think, as Dr. Dimitri said this morning so well, it really is a series of overlapping Venn diagrams among us all in terms of our perspectives on how we move this field forward. So we would very much like to, as part of this discussion, hear different perspectives on how to really capture patient voice, patient priorities in our assessment of value. How does that enter into an accountability framework? How do we think about how that leads to different outcomes in terms of discovery and research? So with that, I'm going to ask each of the panelists to spend a couple of moments introducing themselves and telling us a little about your engagement, particularly in this world of patient-driven value and measurement of patient-driven value. Richard, let's start with you.
Thank you, Helen. So I came to America's Health Insurance Plans via the provider space. I've been a practitioner of internal medicine. I trained in informatics and spent a lot of my career looking at quality metrics and looking at high-value healthcare. I spent most of my career in hospitals and working with large hospital organizations. And when I came to AHIP, I guess there was a question of, why are you here? You're a hospital guy. And what I basically said was, I'm interested in quality, I'm interested in high-value care, I'm sure the plans are as well. And I guess everyone believed it, because here I am at America's Health Insurance Plans. Would you like me to talk about value or just?
Yeah, I think in particular, what's the plan's perspective in terms of how they would look at value, particularly as we heard, I think, in the first panel, the difficulties sometimes patients have encountered with their plans and perhaps the differing concepts of value and how that might relate to a plan.
So I do like to start always with the patient perspective, because I like to remind people that we're all patients, and if we're not, we're going to be patients at some point in time. And when that day comes, we do want access to the most innovative, effective care possible. So that's a very important perspective to start with. I think the plans share that perspective. I think in looking at value, you ask some basic questions. How does it affect my life? And what is the experience of the care? And I think we heard some great stories about how it affects people's lives and what they value there. Does it extend my life? Maybe that's not the most important thing. Maybe the most important thing is that I'm able to run the next marathon next year. Maybe the important thing for me is that I fight, and I'm a fighter, and that's a very important part of my value system. So it's really important to know that. And then the experience of the care, do I have to spend 2 days out of every week getting an infusion at the doctor's office? Do I have to go into the hospital? What will be the experience to me in terms of my relationship to my family? I think what the plans bring is another perspective, which is a perspective of access and sustainability. And I think, one of the things that one of the chief medical officers said to me was, 7 is the new 3. And I said, what in the world are you talking about? He said, well, I used to worry that drug therapies would come out priced at $300,000 a therapy. But now I worry that they're priced at $750,000 a therapy. And that's a real concern. And the concern is, well, everybody wants innovative therapy. There's no question. I certainly want it if I'm a patient. But is it sustainable? How do we find a way to make it accessible, right? Because if nobody can afford it, then it's really not going to be worth having. So we need to ensure sustainability and sustained access to these wonderful therapies. And that's a perspective that the plans share, I think, with a lot of people.
Perhaps a good handoff to you, Dr. Keller, your perspectives.
So I am working in Pfizer. I'm an oncologist, and I'm leading a group that, among others, deals with the problems of beyond the pill, because pharma today is not anymore just a producer of medicines, it's not just a trial organizer. It is truly what we want to be, and what we are trying to be is to fulfill all the aspects of what the patients in the first panels talks about. So what I took from the panel, which is so relevant to the work we are doing in Pfizer, is that all the patients actually had the same theme, and the theme was I have a good insurance, I want a good doctor, and how do I find him? How do I find the connection with the doctor that is fitting my needs? And then do I have the medication that give me hope? And what was very important, the constant theme of the family, of the children, of husbands, of the entire life, actually, of the patient. So to be a contemporary pharma and to be a contemporary patient partner, we do have to understand what the patients are. So one of the aspects of the work we are doing in Pfizer is truly learning how to understand the patients. We understand that every patient has different needs. We understand now, and believe me, we had to learn it over the last several years because it is a very new topic to us when we were busy with the research. It is very important to create, and I can give you several examples what we are supporting, what we are creating in-house within Pfizer, and how we are trying to connect with the patients beyond giving them the medication.
Great, thank you much, Dr. Schwarzman.
Well, first of all, I want to thank the organizers for the opportunity to be here today, a very exciting conference. So my background is at the West Cancer Center, which is in Memphis, Tennessee, and started as a community practice some 35 years ago with a focus on clinical trials, which was novel at the time because 30 years ago, all of the clinical trials were conducted at major academic centers. But because of the growth of community oncology and the educational programs that trained fellows to go out into the community, we can be proud today that virtually every community in America has an oncologist who have access to all the information, if not all the trials, but most of the resources to treat patients effectively. And our focus over those years has been to offer patients cutting-edge and state-of-the-art technology and therapies, because what we found in my area in Memphis, and we draw from about a 100-mile radius, a relatively poor area, an area that has many health challenges, including obesity and in the past smoking and other factors that lead to increased incidence of cancer, is that most people, even those who have means, actually would prefer to stay home and get their cancer care. They value that. And that's not unexpected. You really want to be with your family. You want to be with your community. You want to keep working if you're working while dealing with cancer. So our focus has been give the patients what they need in their community when that is appropriate. And for the most part it is, and there are certain cases, as we heard in the last panel, where going to a particular center for a particular trial is absolutely the right thing. But for standard of care, most patients are going to stay home and frankly don't have the means to travel, and we've found that time and time again. About 5 years ago, we entered into an affiliation with the University of Tennessee and a major hospital system and created a community academic hybrid, which is a new model that's been developing, and there are several instances of this around the country. I think we're seeing consolidation of care in general between academic centers and hospital systems that are partnering or acquiring oncology practices. And I think that can be a good thing because it gives more resources to patients through that affiliation. And I have focused on two things of value, 2 points of value for patients. The first is taking care of many underinsured and uninsured patients. The things they value are very elemental. It's having transportation to get to the doctor. I can't tell you the number of patients who can't get into a clinical trial because they can't come for all the additional services and the visits, or even come for their radiation treatment every day because they don't have somebody to watch their kids or they don't have a reliable transportation. So one of the things we're working on, for example, is a pilot project with Uber to get patients. These are the very simple building blocks, but you perhaps would be surprised how often this becomes an issue and a barrier to patients getting standard care, let alone state-of-the-art care. And the other thing is patient-reported outcomes, something that we've been interested in our practice for 15 years and have been measuring that through electronic systems. And it's been very gratifying over the last couple of years to see that rise to the forefront, even to the plenary session at ASCO this year, which was personally very gratifying because we think that measuring and keeping patient-reported outcomes and seeing longitudinally what happens to symptoms is really important. And we haven't focused on that. In the context of busy practices where physicians or providers have 10 or 15 minutes with a patient, it's really difficult to get a comprehensive view of the patient's symptoms and to address them. And new value-based systems are looking at that carefully, and having technology to measure that and to impact on that is very important.
That's great, thank you. Dr. Hillard.
Hi, so I'm Randy Hillard, and I'd never much thought about cancer, to be honest. I thought about going into it when I graduated from medical school in 1997, but at that point, the treatments were so ineffective, the side effects were so bad that I didn't think I could handle it emotionally. So I went into psychiatry, and that was great until Halloween 2010, when I was at the Student Health Halloween party, probably wearing a stupid mask, and I got out of breath walking up one flight of stairs, which I realized was not normal. Turned out my hemoglobin was 7, should be between about 14 and 16, so somehow I'd lost half my blood without noticing it. And one thing led to another, and by the end of the year, I had lost my stomach and various other organs, and I'd gained a diagnosis of metastatic stomach cancer and a prognosis of about 6 months if I was lucky. And fortunately for me, Herceptin, originally a breast cancer drug approved in 1997, was approved for stomach cancer just a few weeks before Halloween in 2010. So this is an important day because I get to meet with all you guys. But tomorrow's an even more important day for me because it's my 113th Herceptin infusion. It's also the day I retire from Michigan State University. But in order to avoid having to deal with Medicare paperwork, I've taken another full-time job, though I would rather relax. But I would rather have to work full-time and not have as much paperwork as I would have with the Medicare. Anyway, when I was first diagnosed, I got interviewed by Psychiatric News, and the question was a softball. How has being a psychiatrist helped you to deal with being a cancer patient? And my answer was, well, it helped me realize that I was completely insane. And I do think that one of the difficulties that all of you clinician ones have to deal with is that we are all insane. And if that weren't bad enough, each of us is insane in his or her own special way. And being an obsessive as well as a physician, as soon as I got my diagnosis, I went on PubMed and read everything I could find about stomach cancer, and each thing I read made me even more depressed. So my next research project was looking at assisted suicide organizations, because it was really clear to me at that point that my prognosis was not really good. I had seen horrible abdominal deaths during medical school, and I stopped among other insane things, I stopped my antihypertensives because I was thinking probably a cardiovascular death was preferable to an abdominal death. And anyway, so I got in touch with an organization in Switzerland called Dignitatis. I think they probably still have my card on file there someplace. And my plan was that I would just have as much fun as possible for about 6 months, and then when I relapsed, I would go ahead and kill myself. Anyway, I'm glad I didn't go that route. And it was only because of two things. Number one, it was the intergroup 0116 study showing that active chemoradiation therapy did not only improve your quantity of life, but also your quality of life after stomach cancer. And then second, it was the approval of Herceptin. Now, from a value point of view, Herceptin was approved for stomach cancer because it increased the average survival for metastatic disease from 11 months to 13 months. And anyway, I thought, well, at least I can give this a shot. If I don't like it, I can always get back in touch and start with Dignitatis and start planning my ultimate Switzerland vacation. But the good news is I'm alive, I'm well, I feel great, I have no evidence of disease. The bad news, though, is that for my 113th infusion tomorrow, my insurance company is going to get a bill for $19,786. And so you multiply that times 113, and you get a pretty big number. In my more depressive moments, I've sometimes sort of wondered whether I was worth it. But that way lies madness, so I don't think about that too much. But the other thing I think about in terms of both my particular insanity and also in terms of value is that when I hear the word value, I become even more paranoid than usual, and I think all of us patient ones do. Is value going to be a code word for writing us off and leaving us for dead? And let's be honest, we're at risk for that. And one of the things I'm really enthusiastic about this conference is that I've worked on other value conferences, and generally the question is, who are we going to demonize next? And, you guys all represent good targets for demonization. Sometimes even we as the patients get demonized in terms of, nobody ever says it outright, but they do kind of think that we're stupid or insane. I've admitted to insane. The chemo brain's got me into the stupid category a little bit too, but I don't think about that either. But I'm not willing to make compromises as a patient. I don't think anybody is. That, my treatment's over $2 million. And to say, remember those Clearall ads, the most expensive hair coloring you can buy? Well, yeah, and I'm worth it.
Great.
And all of us as patients believe that we're worth it. That, there are some serious problems, and that we're going to need to come up, that clearly if everybody in the country ends up having to spend $2 million to get their personalized treatment, we are going to start running into some financial constraints as a system. And as patients, you can't really ask us to be the ones who solve that problem. I do think, though, also, we're a difficult educational problem in that I have a lot of sympathy with like the clinicians that, you have maybe 15, 20 minutes to really try to explain what our options are. And every time you talk with us, we have different things in mind. I really love nurses and social workers and financial counselors, but frankly, the physicians ultimately have to answer all of our questions for us. So I think this conference is really going beyond that's actually one of my New Year's resolutions, no more demonization. Although I am making an exception for Donald Trump.
On that note,
but anyway,
thank you so much.
So happy to be here. So happy
thank you so much. You've raised so many important questions, all of you have. And as we reflect on this, really a pretty significant shift in the way we're thinking about both the delivery and the payment of healthcare to be about value. Most of us use Professor Porter's definition of the idea that it's the outcomes of most important to patient, the outcomes delivered to patients over the cost of delivering care to patients. I think that really raises the important question, as we heard earlier, what's most important in terms of the outcomes of care to patients? And you certainly raised lots of issues around survival. A couple of you raised issues around quality of life. How do we kind of get our heads around what would be the next set of measures we would use to really reflect on what is value, particularly if that's going to be the way clinicians and healthcare systems are paid for it? Dr. Schwartzberg, you specifically brought up PROs. I'd love your sense of thinking about how patient-reported outcomes in your practice could be used potentially as a way to think about quality of life or other metrics of importance to patients.
Yeah, thank you. So I think we have focused, our original focus was on getting a complete system review of systems for the clinical visit, but it goes beyond that and asks psychosocial questions and asking questions about activities of daily living, as was brought up at the last panel as well. So I think we need to bundle those together and start to experiment with ways that those become patient satisfaction outputs. Which right now they're clinic-facing and they're clinically facing. So they can be altered to look for patient satisfaction. Currently, we're judged on Press-Ganey scores, which many of you may know are questionnaires that are used fairly broadly, I think, across hospital systems and institutions to measure. And it's interesting what patients, in that particular survey, what patients value most are, first of all, waiting time, which is always too long. And secondly, their interaction with the physician. Just as you said, did I get what I thought I needed from the physician? And if you look at all the other factors in that score, which are important, things like cleanliness and the attitudes of the staff, it sort of comes down to, it's driven mostly by what was my interaction? Was it good? Did I get what I need from my physician or my provider that day? So that's a good start, but I think we have a lot to learn in how we move patient-reported outcomes to patient satisfaction scales that can be measured and that are more holistic and more global.
Yeah, and I think even beyond satisfaction, I think you mentioned Ethan Bash's plenary session at ASCO, this remarkable paper, for those of you who've seen it, that looked at the effect of patient-reported symptoms and their symptoms being addressed as actually having a survival effect. And in and of itself, that was so extraordinary to see that even compared to other therapies for metastatic disease, that the addressing of symptoms in a timely manner was another potential way to think about it. Any reflections on that?
Yeah, so we're very excited about that. Actually, Ethan spent some time with us when he was a senior fellow looking at our system, and then went back to Sloan Kettering and started his own system. So it was very gratifying to see that. So the idea that even in a world-class center, if you have a methodology to measure symptoms and to act on those, and I think that was the important point. There was a linkage back to the healthcare team through email or text messaging, so that those symptoms remotely could be acted on in between the visits at the point of care. That's what possibly made the difference. Definitely reduced emergency room visits. Interestingly, they looked at one of the things that was talked about in the original paper was patients who were technology naive actually had the biggest impact. And that's a very interesting observation. So it wasn't that you had to be so facile with the internet. You just had to have some access, and that was enough to create that linkage. Absolutely. And that linkage led to a 5-month survival. If that was a new drug, Maria would be very excited about that, and in her company. And this is something that everyone can do today, and implementing patient-reported outcomes in a longitudinal and comprehensive fashion. I think its time has come now.
That's great. And maybe Dr. Kohler, I'll turn to you, certainly with that perspective in mind. I know the FDA requires patient-reported outcomes as well. What's your sense of what value looks like from industry, and how does that align with the value discussions we heard earlier, and certainly from Dr. Hilliard as well?
So the value is probably a very individualized thing, because, and we actually are working on several projects to first understand the value. And we are sponsoring a variety of initiatives to understand the patient's priorities in the care. We are very, very involved in the shared decision-making with patients and physicians, and this was also brought up very clearly in the early panel, when what was important to patients is to find a physician who understands that they are able to make some decisions that serves their needs, and it's not necessarily a common decision for every patient who has chronic myeloid leukemia or sarcoma. It's really about the patient. So the value is, as I said, in the eyes of the beholder. And if someone has a broad family and no insurance, the value of the treatment would be such that they don't want to burden the family, they don't want to leave the family in some sort of situation that everybody will remember. The other situations is that some patients say, I can do anything, I can take any toxicity, I can do anything, I just want to live. And some other patients are saying, well, I really value my quality of life, I want to be with my family, I want to live my life as close as I could. And what we learned over the last few years that we are doing this research is that patients really value the understanding, and I think that the understanding of the caregiver and understanding of the community. So one of the things that we are actually doing currently is proposing to patients a technology, just because it's something that we can offer the patients in the beyond the pill concept. We are providing the patients with an app to help the patients connect with what we call circle of trust, which is connect with some either family member or friends or coworkers because sometimes the patient is not comfortable asking for help, but patient would ask for help via an app because it's sort of less personal. And then the app can help the community that the patient creates, and every patient does an individualized community for themselves. Posts on the app, I have a problem with my dinner tonight, or I cannot take my kid to a piano lesson or something. And then the community with small circle can answer and say, well, I can do it for you, I can do it for you. And it's not very big burden if you do it on and off for a friend or for someone who is in your circle. So this type of simple tools that we can provide to the patients in collaboration with the physician is something that we believe helps patients deal with the burden of cancer and helps patients make the experience with cancer care probably better.
Great, very helpful. I think a big issue we heard certainly in the first panel at times was a sense of patients saying, this is what I want, this is what I need, and not being listened to. And I guess, Dr. Hillard, from your perspective, I know you've had some interactions with FDA as the patient representative. Can you share some of that perspectives of what is it like to bring patient-reported data and have it be seen as high value in some of that decision-making?
Yeah, well, interestingly enough, the side effect that I have that's bothering me the most is that my oxaliplatin made me somewhat deaf, meaning I only got about half of your question. But being deaf isn't usually that bad because you just smile and agree with whatever anyone says, or, unless they ask whether their dress makes them look fat. And then you also can answer, what you think is most likely to have been asked. But I do think that I don't have a lot of trust in these like quantitative measures. Fill out this questionnaire and you'll find out what treatment is right for you. Because it is different that as an obsessive, which I admitted to, as well as being suicidal. I wonder if I'm going to be employable in the future.
You're really on a roll, yeah.
But anyhow, that for me, you would think that kind of questionnaire would be really good. And when I first went in to get my treatment, I was thinking through all kinds of things like pseudo-mathematics. And now if I can project with the treatment, I will have more good days than BODDs or JAWDs, which is better off dead days and just as well off dead days. Then it would be rational for me to choose this treatment. But of course, it makes sense the same way that like QALYs make sense. But when you try to get them down to the individual level, it doesn't quite. And so I think it's also a fantasy sometimes that you can have one conversation with your patient. They will understand what their options are. Really, every single time you meet with a patient, which is a time when the patient's making a decision whether to go on or whether to give up.
Yeah.
And when I was going through denial, anger, bargaining, depression, acceptance, soon after being diagnosed, like Elizabeth Kubler-Ross, stages of death and dying, when I was rotating through bargaining, I at one point decided, okay, great. So if I am not a hospice patient in a year, I'll be a hospice doctor. So I'm doing that part-time, but it's really created even more cognitive dissonance for me because the patient survivor community, which I'm part of, our goal is never give up, never give up, never give up. And for the hospice community that I'm also part of, the goal is, know when, we don't want to say give up, but know when to stop, pursuing cure. And so I think every time we go in to see our patient, every time we go in to see our doctor, the way those are balancing out is different from one visit to the next. And what I've kind of done is thought sooner or later I will end my days in hospice. And the way I'm going to conceptualize it is that it's not giving up. It's just that's how I'm going to continue fighting. It's from hospice rather than the ICU.
Yeah.
I hope that answered your question, whatever it was.
It answered a question. It was great. Thank you. I actually want to turn to you next, Richard. I think one of the things we think a lot about as we think about infusing patient values into the way we assess quality and value is this sense that we need to make room for that. That's not easy data to collect. Dr. Schwartzberg's a great example of doing it successfully. It's still very difficult to build that into practice. And just a quick personal anecdote, my father passed away about 6 years ago of metastatic bladder cancer and was in the hospital with urosepsis, and he was looking really bad. And as his daughter, I kind of desperately wanted to check his blood pressure because it's the daughter-doctor thing. Mm-hmm. And I resisted that urge, and then a nurse came running, and I was so pleased she was coming in. And she turned to my father and said, "Mr. Burston, have you had a pneumococcal vaccine?" It was just one of those moments of thinking, wrong time, wrong place. Mm-hmm. Besides the fact, if we think about how health IT systems and others connect, he'd been a patient in that health system for 20 years. His pneumococcal vaccine status was right. So I guess the question for you, Richard, as we think about this pivot away from the measures we've been using for a long time, heavily oriented towards claims, heavily oriented towards process measures we can measure, and make this pivot to outcomes, how do we move this ship? And what's your perspective from where you are at the plan, or even your prior work, certainly at Premier?
It's a good question. And we've worked together and we sat at the Measures Application Partnership of CMS, and we've reviewed all of the measures, and I've sat on the NQF technical panels. And one of the things I've tried to keep in my mind, and I've tried to state as a mantra, is measures must matter.
Yes.
And I think sometimes we've gotten to the point where the measures maybe don't matter.
Yeah.
And it's driven by the crazy incentives that are in the system. So it's sort of this check the box. I gave the pneumococcal pneumonia vaccine. I can check the box and my numerator is going to be that much higher. And then maybe I'm going to get 5 stars instead of 4, and maybe I'm going to get a little extra money from CMS this year. And so we've kind of diverted. The tail is sort of wagging the dog. We're trying to check the boxes frantically because that's what the payers of CMS certainly are looking at.
And the plans.
And the plans follow suit. And I think if you take a step back, everyone's heart is in the right place. We do want to ensure quality. We have to have some way of measuring quality, and I think it's important to take into account the conversation we're having today, which is what really matters. Right. And it may not be the pneumococcal pneumonia vaccine that matters. And so what does actually matter, I think we've talked a lot about it, and you've started off with the equation, outcomes over cost. I would add to that equation, I would say outcomes times experience over cost. But cost isn't really even fully capturing it, because it's the cost today. Is it affordable today? But it's also the financial security. Will I bankrupt my family? Right. So what is the long-term cost? So if we take a step back and use the patient perspective, I think we kind of get the answers. What do I value? How does it change my life? And we talked a lot about it can be life expectancy, but it also can be functionality. It can be lack of pain. It can be more time with my family. Many things. And the experience is so important. Sometimes it's inextricably linked with the outcome. The side effects, the amount of time you have to take off work or take away from your family to go get the treatment. The communication with the physician, as we've seen, can be actually part of that outcome. So we need to try to think of ways to capture it, and it's not easy, but it's certainly necessary. And I think we are trying. I think people now are starting to realize that it's important to really focus on measures that matter. And I think the effort to move in the direction of patient-reported outcomes is a very good effort. And it's going to be made more complex because you have to have sort of a wrapper around it, which is the context of the patient preference.
Right.
And so your questionnaire might look exactly like my questionnaire, but we might have a totally different value because I might value other things. Being a fighter is paramount for me, and maybe having more comfortable days at home is paramount for you. So it's a very big challenge. I think we know how we're not going to get there. We're not going to get there by continuing to force providers to simply check boxes.
Couldn't agree more. So as we think about this, and maybe just a question for Dr. Schwarzberg, building on, you raised the issue clearly of patients, the difference between the haves and the have-nots. And I think as we think about this move forward and all these new discoveries and the ability to access the care you need, how do we think about what we can do as part of this move towards value to make sure we're not increasing disparities? I mean, we heard an incredibly impassioned, well-informed panel who pushed for what they wanted. What happens when patients don't have that kind of advocacy?
Yeah,
So-
I'm sorry, feel free, either one of you, please.
Oh, go ahead, Mary. So I think this is a growing problem. We have, Dr. Dimitri mentioned the incredible breakthroughs that have come over the last couple of years, and just as one example, we actually mentioned both examples that have different challenges. So immunotherapies and the cost of them, particularly taking them for long periods of time. Patients who don't have access to those drugs, we may be creating more disparity between the haves and the have-nots when we have expensive but incredibly life-saving,
Right.
perhaps curable therapies. And then we have the orals, which have come in the last 20 years, and the TKIs that he also mentioned, that have their own set of challenges. And much research has already shown that even the first prescription is not filled in 10 to 20% of the cases because of the copay and the sticker shock that the patient gets, or has to go through the specialty pharmacy and all the hoops to jump through. All of these things are very basic blocking and tackling, but they're so important because if we don't get that right, we can't get to the higher level, which I totally agree with, that the value is based on outcomes and experience, but you have to have the drug to do it. So in my own area, we have the dubious distinction of having the largest disparity in breast cancer outcomes and colon cancer outcomes in terms of survival between African Americans and whites. And so we're working on all levels of that. It's a difficult problem, and it's not just one thing. There are many elements to it, and they all have to be addressed. From biological differences, perhaps, to access differences, to cultural differences, to where you interact with the community. In our particular area, a faith-based approach seems to work for many. So, but I think experience is going to be different. And so I'm very gratified that NCI has started to really think about this and has made disparity research such an important component going forward for the cancer centers.
Great, thank you. Dr. Kohler, do you want to add something?
Yeah, see, I think that the disparity is a problem, but it is not only a problem with access to drugs per se, but disparity is a problem on its own. And we are participating and actually co-sponsoring the Common Health Equity Initiative, which is an initiative of 10 cities which are known for disparities, such as Chicago or Dallas or Memphis, and 7 others. And the disparity problem always starts with education also. Do the patients, the communities of African American and other poor communities, do they have access to clinical trials? Do they even know what clinical trial is? Do they have access to very simple education? And the Common Foundation is supporting this type of initiative. There is several other initiatives that we are helping to co-sponsor, such as the Sisters Network or National Urban League. And all these initiatives are both helping patients to deal with the early life, with the daily life, but also helping the physicians to help patients, because the patients need to be in the office when you need to help them. So the disparity on its own is a problem indeed beyond really even the cost of the drug. It's not only the medication.
Absolutely. Yeah, please, Dr. Hill.
Yeah, in terms of disparities, what I have is adenocarcinoma of the distal stomach. And that's mostly a disease of poor people, black people, Hispanic people, first generation Asians. I think one of the reasons that Herceptin was not approved for stomach cancer until 13 years after it had been approved for breast cancer is that it's mostly a disease of people who don't have much of a voice. I think that the approval of site agnostic treatments is really good because it, for so many reasons, but because it does get us into research for socioeconomically associated cancers. My stomach cancer was caused by Helicobacter pylori infection, which causes most of the distal, like adenocarcinoma. When I was first diagnosed, my thoughts in the gallows humor phase were, well, this is great. I've got a fatal cancer. It's not even one of your more popular cancers, and it was 100% preventable. That, although my treatments cost over $2 million, about $20 I could have been tested and treated for Helicobacter. Had an aunt who died of stomach cancer. That really, we have the potential for really health technology to really have something that pops up, family history of stomach cancer, test and treat for Helicobacter. And I think that's one aspect. I think that the system now, even if you don't have insurance, you can probably get access to the best treatment. The problem is, though, that if you don't have insurance, you probably also, as you said, don't have the ability to get to your appointments. You probably don't have the sort of health literacy that you can have, like, your options explained to you quickly. And so ordinarily when people think about disparities, it's sort of like access to treatment that pops to mind first, but the most important things, I think, are a lot more complex than that, and that one of the main ways we can help with disparities is to invest a little bit more money in the, well, a lot more money, in the low-tech aspects of how do we help people get to their appointments? How do we give people the amount of time necessary to really bring their understanding up to where they can make rational decisions?
Right, and doing that really requires, having data on social determinants of health. Mm-hmm. So thoughts about how we even begin to capture some of that information. Richard?
Yeah, I was going to say, I totally agree that disparities go beyond just access to therapy. And I'm thinking of that wheel of the things that affect healthcare outcomes, and 10% is healthcare treatments, 30% is genetics, but that leaves 60% that's behavior and the social determinants of health, which include financial, healthcare literacy, familial support, all kinds of things go into that equation. So I think it's important to measure those things, because even with the best of care, that outcome is determined by these social determinants of health, have a big impact. Now, one of the things that some of the plans are doing is trying to address those disparities by directly addressing the social determinants of health. And Anthem, I know, is working with Pfizer and this coalition to try to increase breast cancer screening in African American communities, because those communities tend to underutilize screening, and that's so important. Harvard Pilgrim is working on a project to look at not only racial disparities, but healthcare literacy disparities. And they have a program that is actually trying to increase the rates of colon cancer screening. And they have been successful in shortening that gap between 11%, those who have healthcare high literacy and low, to 4%. So that's incredible. So we have to address not only the therapies, but access to screening modalities and access to healthy food. Those are so important. Access to playgrounds. And you ask about how do you measure it. Well, once again, it has to be measured on many different levels. It's not just a plan or a provider, but it's sort of a community measurement too. How good is the food in that community? How good are the playgrounds? What's the crime rate? Can people actually get to public transportation? All those things are important to measure.
Yeah, and all those things are difficult to capture.
They really are.
Which I think is one of the challenges for all of us, but hopefully data increasingly we get in and bring inside our research perspectives of what's equally important to understand in addition to some of the genetic factors. Any other thoughts about that issue before we move on to something else? All right, so I'm sorry, go ahead, Dr. Rosberg.
I just want to echo the point about social determinants of health, and I think in breaking down the barriers, as Joe Biden has talked about, I think breaking down the barriers between research and basic and translational research on the science side with social scientists, so we can really get to the social determinants of health, and working together would be one of the most valuable areas of opportunity to make some progress in that.
Absolutely. We also talked on our planning call about how does the whole concept of shared decision-making factor into bringing the patient's values, sharing the knowledge they need to make an informed decision. Thoughts about how that fits into our conceptualization of value? Anyone?
Well, I would start in terms of shared decision-making. I think the most important thing we have to address is communication. And I think I was reading last month in Kaiser Family Health News that many patients don't have discussions with their physicians about life expectancy or even why they're getting a particular treatment they're getting. And so you can't have any shared decision-making unless there's that communication. So that would be the first thing to address.
I think increasing health literacy has been mentioned on this panel. You can't have good shared decision-making unless the health literacy is at a point where communication is being interpreted between the provider and the patient. It's getting more difficult, frankly, as we move into areas where now cancer is becoming more and more complex and more subgroups. It's hard even, one of the debates that's going on is how can people be generalist oncologists going forward? It's very, very difficult. Look at lung cancer now. From treating everyone 5 years ago with one combination to 15 different diseases with specific mutations, it requires an incredibly deep understanding of that disease, and then trying to explain it to a patient is even more complicated. So I think that's where the focus should be. To get to shared decision making, we first have to find tools to increase health literacy in a way that makes sense and are efficient, time efficient.
Absolutely, please.
Yeah, I think one of the things that people mentioned on the first panel was doctors being upset if you ask them questions. And so I've got a 4,000 patient Facebook group on stomach cancer, and my main contribution is ask your doctor these questions. If your doctor won't answer them, find a new doctor. On the other hand, not everybody wants, and I think it's difficult because not everybody wants to do shared decision making in the sense that in a way that we with high health literacy sort of think it would be nice if everyone did. But a lot of patients, I think maybe most patients, want you to be the doctor, and feel that you really do know what my values are, and you're going to make recommendations consistent with that. And I don't have to go take a new course in how to interpret statistics and stuff. Mm-hmm. So I think that's one of the most difficult things that you face, is knowing where on the spectrum your patient is. The ones who want to know everything and feel like they're making all the decisions. On the other extreme, the people who want you to be the doctor make the decision for them. And it's a spectrum, and I think at different times all of us fall different places along the spectrum. So I just really admire you clinicians so much.
I would like to bring two items here about the cancer literacy, because this is really where the problem begins with the diagnosis. And there is the cancer support community, which is currently over 12,000, both patients and caregivers, who are able to get the immediate information. This is a community of mostly social workers and other professionals who are able to give the patients information. And also, let's not forget the very reliable communities which serve patients, just like patients like me, or cancer, various organizations. The Patients Like Me is an organization that is not specific to cancer, but links patients with the same diseases. Started actually with one of the rare neurodegenerative disease. So I think that if we believe that, if we know that a few years ago, it was just even unheard of at the time of chemotherapy, that something like this will really flower, and we will have the opportunities to increase the literacy solely by patients themselves, because the patients expressing the need for information eventually get to the source of information. And it is undescribably useful to have this opportunity to be a member of these communities. And even what you mentioned, the Facebook things, it's a very, very easy community. Whether this is reliable is a different item, but that's the current technology problem. But what we are doing, and what we found extremely important, is to truly increase the education and truly increase the collaboration between patients themselves, because these are the motivated patients who themselves create the help for the other patients.
Yeah, it's interesting. You mentioned the online communities, and Dr. Hillard mentioned Facebook. There is a real movement of patient-reported data entering into the realm of how we consider research. And a recent meeting between Patients Like Me and the Duke Margolis Center, for example, really thinking about what would it take to bring patient-reported data into the realm of research and discovery. Dr. Hillard, you spent some time on an FDA panel in that realm.
Yes.
Any perspectives there as a patient member?
Yeah, no, I was very fortunate that I got to be on the panel that approved the first biosimilar drug, which was filgrastim. And I have a lot of sympathy for the FDA, because they get nothing but grief from everybody, regardless of what they do. But being the patient representative on their panel, I was a little afraid I would be like the mascot. But no, I really felt that they respected me and they listened. And the way that you vote on those panels is, it's kind of like this. You go around, you vote anonymously, approve, disapprove, and then you go around and then say how you voted. And being the lowest status person, they came to me last. And my comment was that I think this drug has been shown to be biosimilar, and would like to see it approved, and I'm willing to bet my life on it. And that's kind of what we're doing, and I think it's one of the things that patients really do have to contribute. And I'd also think, too, that health literacy, I think anybody can understand, like, the important aspects of their treatment and the decisions they have to make. It just takes a lot longer for, to bring people up to speed to figure out what they need to know. So, anyway, FDA.
Not demonized today. Other thoughts on shared decision-making, or even perhaps how we begin to have it enter into our measurement of an assessment of value of were patients feeling sufficiently engaged as they chose to be, but did they get enough information to feel like they could really be a partner in that decision-making?
Well, one thing I think we have to remember is in the subject of shared decision-making, even the most intelligent people make cognitive mistakes, right? And interpreting probability is very difficult.
It's really hard.
And I think we need better tools, right? I've seen some interesting tools that take a theater like this and they blank out the seats and try to give a visual interpretation of what 2 out of 1,000 means. And I think we need to incorporate those tools into training, into medical school curricula, because I'm not sure we're doing a good job of that.
Yeah,
and
certainly physicians have an issue with numeracy, I think, really
all
understanding
humans do.
probabilities. And so it's really then hard to be able to effectively, I think, describe that to patients in a way that...
It is. And patients everyone discounts the future. I mean,
yeah.
It's a behavioral economical finding that you tend to discount things and that you think, well, that's not going to happen to me.
Yeah, and many decision aids are particularly useful here. We just came up with a set of criteria upon which you would be able to rate whether a decision aid would be useful for a patient. I think it's really important that we put the right tools into people's hands. Interestingly, just that there's a recent tool that's been developed that'll come to us shortly called Collaborate, which is just a very simple 3-item questionnaire that patients are asked about the degree of engagement they've had in terms of making decisions. They get enough information. And the first time I saw the lead investigator is a professor named Glenn Elwin at Dartmouth. And it's got a 1 to 9 Likert scale for each question. I thought 1 to 9 as a measurement wonk, that's kind of unusual. 3, 5, maybe why 9? And his response was very simple, which is this was developed from the start with the idea that this is a tool. There are 9 buttons on a cell phone, and patients should do this on their cell phones as they're leaving the office. So again, how can technology potentially be useful here? How can we develop some of these newer tools and these ways to reflect value that perhaps are easier to do, in the way Dr. Schwartzberg's been able to do it in his office, but be able to sustain that and drive towards innovation. I think she's standing up. With that, I'm going to ask you to thank our panelists for a great discussion, and thank you again for inviting us.